Welcome to Spine Academy. In this chapter, we're going to discuss the symptoms of cervical spondylosis. In previous chapters, we've discussed not only the specifics of cervical anatomy, but also understanding cervical imaging, and then we really spent some time talking about the features, anatomical features, of cervical spondylosis. In this important chapter, we're going to talk much more about the symptoms that patients might encounter if they have spondylosis. So the symptoms can typically be broken down into a few different patterns, and we'll start by going over an overview of what those patterns are and how they relate to each other. Then we'll drill down a little bit into cervical myelopathy, talking about not only the types of symptoms, but the distribution of those symptoms, as well as exam findings that are encountered with that. We'll switch gears to talk about cervical radiculopathy with its distribution of symptoms and the classic symptoms associated with that. We'll talk again about exam findings related to cervical radiculopathy. And then lastly, we'll talk about neck pain to the extent that it can be attributed to the cervical spine. There are obviously a variety of different things that can cause neck pain. Now, the reason for really coming up with this pattern or the structure for it is because it's very important to think about symptoms in a structured way to help dictate what treatment options and timing are available down the road. It is very important to kind of understand that patients can have symptoms of any or all of these at once, and understanding which ones they have specifically will have important implications for downstream management. It's very important to understand the symptoms of cervical spondylosis in an organized way. Whether you're a patient trying to understand your own symptoms and make sense of them, or you're a clinician of some sort trying to understand and break down the symptoms that your patient is having, it's important to kind of think about where the symptoms themselves can come from. In the cervical spine, here you can see very nicely, we're focused on this particular area of the spine, so the neck. Of course, can cause neck pain, and as we have covered in prior chapters, arthritic changes here can cause symptoms of neck pain, but of course symptoms from pressure on the nerves and the spinal cord, and that's what we're going to drill in on a little bit more. This video here will give you a better sense of the relationship between the brain, the spinal cord, and the spinal nerves themselves. We have covered the fact that the spinal cord itself runs up and down from the brain downwards. There are branches called spinal nerves, and you can see that there's one leaving on the right and one leaving on the left here at each of these levels. The spinal cord is like a tree trunk. It conducts all the signals from, in the case of a tree, from the ground all the way up into the branches out to the leaves. Here, the spinal cord conducts signals from the brain down through the spinal cord into the branches that are called spinal nerves that then descend further into other nerves and into a rich network that goes all the way out to your fingertips in the arms, but down even into your legs. So the spinal cord in the neck will, of course, even affect symptoms in your chest, abdomen, down into your legs. The relationship between these structures, so here you can see the spinal column surrounds the spinal cord and the spinal nerves. So arthritic changes here, whether it involves the disc or the bone spurs in the front or the joints in the back here, ligament in the back there, arthritic changes here can cause pressure on some of these structures, and that's really what gives rise to two of the very important categories of symptoms that we see. This MRI scan shows some arthritic changes, and here you can see again, this is a sagittal sequence. Here's some disc degeneration with some bulging at the C3-4 disc. 4-5 and 5-6 similarly have some disc material. There's some ligament thickening in the back, and the spinal cord is really being squeezed front and back by the arthritic or spondylitic changes, and as a consequence, you can even see there's a little bit of swelling in the spinal cord at that C3-4 level. When you think about arthritic changes, and we've covered this in prior chapters, these frozen sections from Professor Wolfgang Rauschning really highlight the relationship between some of these arthritic changes and the structures around them. So here you can see the spinal cord in cross section. This is a slice like this. There's a nerve leaving on the right side here. There's a nerve leaving on the left side there. You can see that the pressure on the nerve, which is related to this bone spur and some disc material pressing on this nerve, can give rise to symptoms. And similarly, this disc material and some of the bone spurs here, even this ligament thickening, squeezing on the spinal cord here, you can see can cause symptoms related to that. The first two important categories of symptoms or patterns of symptoms that we see in cervical spondylosis, the first one we're going to talk about is called cervical myelopathy. Cervical myelopathy is the clinical symptoms, it's a clinical constellation of symptoms that come from pressure and dysfunction of the spinal cord. That's called cervical myelopathy. Pressure and dysfunction of the spinal nerves is the second category that we're going to talk about, and that is called cervical radiculopathy. And we'll get into both of these in much greater detail in the coming minutes. This is a beautiful sequence or a slice again that's almost sagittal where you can see the arthritis, and really it's worse at these levels. Like these are beautiful looking discs, these are quite degenerated. You can see some of the arthritis involving the joints in the back here as well. And of course, those structural findings involving the spinal column can cause neck pain. So the last category to talk about will be neck pain. So the symptoms that we're going to talk about really fall into three categories that are important to kind of think about whether you're seeing patients or you are a patient yourself: cervical myelopathy, cervical radiculopathy, and neck pain. And we'll get into those in greater detail now. The first of the three patterns that we're going to talk about is going to be cervical myelopathy. So again, cervical myelopathy comes from spinal cord compression and spinal cord dysfunction. This slice, once again, this is an axial slice, and you can see here the spinal cord. So we're talking about the spinal cord as it relates to the structures around it. You can see that there's some arthritis here that's pressing on a nerve, but not really affecting the spinal cord. So not all arthritis in the cervical spine will affect the spinal cord. And in fact, the spinal cord can sometimes have some pressure on it, but have enough room to give where people won't necessarily have symptoms from that. Here you can see there's this disc material here, maybe some bone spur material kind of pressing on the spinal cord, and it's kind of being impressed on or imprinted here by this material right there. The ligament is a little bit thicker on this side as well. And so spinal cord dysfunction comes when there's significant pressure on the spinal cord, kind of more pressure than it can tolerate, and then people will start developing symptoms from it. There's two important things to emphasize. One is that spinal cord compression can come from the front or can come from the back. So this is again the back part of the body or the back of the neck here. Spinal cord can be ventral or dorsal, and that will have important implications in decision-making and how to treat it if it comes to surgery. The other thing to mention is that the spinal cord has room around it. So sometimes there can be narrowing around the spinal cord, or stenosis as we call it, that's asymptomatic, that the spinal cord, as long as it's working okay, they don't have myelopathy. So we don't necessarily care as much about just the fact that there is encroachment. So the symptoms that people develop from cervical myelopathy relate a lot to the anatomy. So we'll take a step back for one moment. This is a slice again through a cadaver. It's a sagittal slice. The front of the spine is here. And you can see the bones and discs here. There's a fairly large disc herniation causing pressure on the spinal cord, which is this structure right there. Now the spinal cord, when you look at it, there's this disc material pressing, and there's some swelling or some signal change within it, this kind of reddish purplish stripe that's in the middle of it, indicating that there is a fair amount of pressure on it, even some degree of spinal cord injury. The spinal cord goes from the brain downwards, and in terms of distribution, that has very important implications. When the spinal cord is not working right here, it can affect the conduction of signals from the brain down to anything past that. So it will affect all of the nerves and neurological function at that level below. It doesn't have to involve all of them, but it may involve anything below that level, just like if you're squeezing on a tree trunk. It can affect the arms and the legs when it involves the cervical spine. And often, because the spinal cord is kind of small and there's pressure on it, the symptoms will be bilateral. So in terms of distribution, when people have cervical myelopathy, it can affect anything from the level of compression down on both sides into the arms and the legs. Now the specifics of the symptoms that people will develop, let's get into them individually. We'll talk about the arms first and then the legs. In the arms, the symptoms that people get with myelopathy or spinal cord dysfunction are problems with clumsiness. So difficulty with things like buttoning their shirt, zipping up their zippers, putting on their jewelry, activities like that. Those are common things that people do on a day-to-day basis, and they see that they have kind of a loss of dexterity with that. Most patients chalk it up to age, but it is a little more rapidly progressive than you would expect with age alone. People will have stiffness in their fingers, so that can affect problems with typing or using their phone or playing the piano or an instrument where their fingers just don't have the same degree of fine motor function or dexterity that they once had. People will often notice that they're dropping objects, and we'll say if they're not paying close attention, they can drop a coffee cup or a cup of water or something like that. Or even like if they're holding onto a sheet of paper, they'll say if they're not paying close attention, it'll kind of slip right out of their fingers. People have difficulty with dropping objects in their hands. All of those fine motor kind of dysfunctions are the classic features of cervical myelopathy in the arms. In terms of leg involvement, and again, not everybody with cervical spinal cord compression will have involvement of their legs, but they can easily have them. And the symptoms that they will develop will be particularly loss of balance. People feel like they're drunk when they're walking. They feel unsteady, like they're bouncing into walls and kind of drifting from side to side. And it's because not all of the signals are making it from their brain down into their legs. And importantly, not all the signals are making it from their legs back up into their brain. They'll have stiffness in their legs, and you might notice that in the walk. It's a little bit Frankensteinish. When people walk, they'll have spasticity into their legs. And people sometimes notice weakness, not always, but sometimes notice weakness with maneuvers, particularly that involve strength in the thighs, so going up steps, getting out of a chair, things like that. People don't have to have that, but that's another thing that people will develop when they have myelopathy involving the legs. So they can affect, again, myelopathy can affect the arms and the legs, and the classic features of them are problems with clumsiness, dropping things, balance dysfunction. In terms of the characteristics that are a little bit unique and don't necessarily fall into those nice categories, it's important to mention that myelopathy need not come with pain. Now again, when people have arthritis, they can have other things that cause pain, but myelopathy unto itself, spinal cord compression and spinal cord dysfunction does not usually cause pain. It can be an entirely painless phenomenon, which is something that really that keeps people from going to the hospital, because nobody wants to see a doctor, nobody wants to go to a hospital if they don't have to. And the fact that it's painless, people often kind of write it off for a while before they finally seek attention for it. Another thing that people will notice sometimes is a Lhermitte's phenomenon. It's not super common, but that's a condition where people will kind of lean forward, or I've seen it even where they lean back, and the spinal cord will get kind of dinged. You could imagine if this person leaned forward and the spinal cord got a little jolt to it, that you'd get a lightning bolt that kind of goes through your body. It's like a shock-like sensation that goes through your body. The name for that is something called a Lhermitte's phenomenon. And then lastly, people can notice numbness that really will affect from that level below. And that's really related to loss of sensory fibers and things conducting back up to the brain from further down. Those are things that people can or cannot notice with cervical myelopathy, but things to just be aware of when you're talking about the symptoms that people will have with it. Now, when you go see your doctor for evaluation for this, one of the things a specialist in cervical pathology or spinal pathology will look for are findings unique to myelopathy. The first and foremost thing is really reflexes. So of course, we'll talk about a variety of different, but reflexes are generally brisk. So we'll check a reflex like in the bicep or the brachioradialis, and it'll be quite brisk. And when people have myelopathy, a lot of patients think that's a good thing because the reflexes are good, but it's not really good. Is just kind of the right amount, so to speak. Like too brisk or not brisk enough, those are things that we really kind of care about. Classically, with spinal cord dysfunction or myelopathy, people will have brisk reflexes or what we call hyperreflexia, and that'll be into the arms and the legs, again, from the level of compression below. Other things to notice will be something called a Hoffman sign, which is a sign of hyperreflexia as well. So if they're flicking your finger, that's why they're doing it. They'll look at some reflexes in your feet. All of that is to kind of gauge your spinal cord reflexes and spinal cord function. And in general, hyperreflexia is a feature of cervical myelopathy. We'll look at the gait. That's the other thing that we'll really think about is like when we'll have people stand up and walk, we'll have you do one foot in front of the other to kind of make sure that's something you can do on your own. It's like a sobriety test effectively. And if people have balance problems with that, it doesn't mean for sure they have spinal cord dysfunction, but that is a potential explanation, part of the picture. So we'll do something called a tandem gait, which is one foot in front of the other, kind of heel to toe, and see if people have any abnormalities with that. We check for sensory loss. We'll check for kind of increases or changes in tone. Classically, people will have some degree of increase in tone. That's usually after longer lasting or longer standing kind of pathology, but we'll see that as well. And of course, do a detailed motor exam to kind of see if there's any weakness. And particular patterns of weakness may clue us into the presence or absence of myelopathy. The reason we take myelopathy so seriously is because a lot of times it does not get better on its own. For the most part, cervical myelopathy is a slowly progressive thing. It's not rapidly progressive. It can be, but it's generally a slowly progressive phenomenon, generally over the span of months. It's part of the reason people don't seek urgent attention for it, because it's such a slow and insidious decline, they don't necessarily seek attention right away. It's usually a progressive thing where people kind of lose function. Most often it's punctuated, which means that people kind of have a certain neurological function, they see a little bit of a decline, a little bit of a decline. They kind of see punctuated decline with periods of kind of stability in between. But what's important is that it generally does not get better on its own. And that while the time course of decline can really vary, the fact that it declines is part of what motivates us to recommend surgery for myelopathy as a general rule. Now, it's something where the timing of that and how quickly, that's something to really discuss with the specialist that you're seeing for. But cervical myelopathy is something we generally recommend surgery for. There are grading systems for severity of myelopathy, and we're not going to get into it in this talk, but you can look them up quite readily. That is definitely a consideration in when and how quickly typically we recommend, and even to some extent what type of surgery we recommend if we get to doing that. But that is kind of an overview of cervical myelopathy, not only the distribution of it, but the features, the exam findings, and the natural history or the course that we expect it to take if people have those symptoms. The next symptom pattern that we're going to discuss is cervical radiculopathy. So cervical radiculopathy, as a reminder, is when people have symptoms from pressure and injury to a spinal nerve in the cervical spine. As a quick refresher, here you can see an animation of the cervical spinal column and its close relationship to the nerves around it. The bones are numbered from 1 at the top to 7 at the bottom. You can see that the nerve comes out of a small window called the neuroforamen, and there's one on the right side and one on the left side at every level. If you look at this disc between C4 and C5, that's called the C4-5 disc. That's the C4-5 level. The nerve that comes out at C4-5 is the C5 nerve. So this is the right-sided C5 nerve, and this is the left-sided C5 nerve. An interesting little artifact, because of the way this is numbered, is that between C7 and T1 is a nerve called the C8 nerve. And again, there's a right-sided C8 and a left-sided C8 nerve, but there is no vertebral body or other structured number C8, only this one nerve. So the nerves are closely related to the spinal column, and I think this picture will kind of show how pathology in the disc, for example, here, can cause pressure on a spinal nerve right here. And you can see that the inflammation in the spinal nerve there and the swelling that is caused by this disc material here can cause symptoms into this branch. It will not necessarily cause symptoms related to spinal cord dysfunction, like in this animation. It also won't necessarily cause symptoms at this side or any of the other levels. It's very focal. It causes symptoms associated with that particular spinal nerve or like that branch of the tree. In terms of the symptom distribution itself, like in this frozen section right here, you can see that there is pressure on the nerve over here. There's no pressure or notable or less pressure over here. This pressure affects that nerve alone. So cervical radiculopathy typically affects only the structures that are affected by that nerve. So usually that's on one side, so the symptoms are usually unilateral and only affecting that. This illustration here shows, for example, inflammation here will not affect the level above it. So let's say this was the C5 nerve. C4 and C6 will typically not be affected. So the symptom distribution usually only affects all of the structures where that nerve goes on that side. Now let's talk about the symptoms that people get with cervical radiculopathy. The classic symptom that people will have is pain. And it's usually a shooting type of pain that we'll get into in some greater detail. But pain is the cardinal feature. In fact, the teaching is if people do not have pain, you have to really question the diagnosis of cervical radiculopathy. In addition to pain, people can have weakness, and it's frequently in whatever muscle groups are affected by that nerve. And people can have numbness and tingling wherever that nerve goes as well. So the traditional kind of symptoms that people will have will be pain, weakness, numbness, and tingling with cervical radiculopathy. Now let's drill in on those a little bit more. Let's talk about pain. In terms of pain, for example, if you look at this nerve, and let's just call it the C5 nerve for purposes of discussion, usually the symptoms will shoot into the upper extremity wherever that nerve goes. So it's a shooting, sharp, electric shock-like lightning bolt type pain that shoots into their arm, for example, if it's in the cervical spine. And we'll talk a little bit more about distribution in just a second, but it's pain radiating wherever that nerve goes. It usually is a classic nerve type distribution that we'll talk to when I show a dermatome map in a few minutes. Weakness will typically similarly also affect just the muscles that are affected by that nerve. So imagine for a second that a nerve is a conductor. It sends signals from the brain down to specific muscle groups or specific muscles. If not all the signals are making it through, whatever muscles that nerve goes to will exhibit some form of weakness. Now, it's interesting that many muscles get nerves from multiple or innervation from multiple different nerves. So you may not be complete. There are a couple exceptions. For the most part, most muscles get nerve supply from more than one nerve. So if one shuts down, they'll kind of have some weakness, but still be able to move it some. The degree of weakness can be mild to severe, and that's a function of a lot of different factors. Weakness need not always be present. So when we're looking at patients with cervical radiculopathy, we'll look at how much pain do they have any weakness, and what's the distribution and the severity of that weakness, and all of that will factor into the decision making around if surgery is warranted or what other treatment options are an option or things like that. And then finally, numbness and tingling. Like sensory changes and sensation changes will be like people may not feel it, or they might have a pins and needles type sensation that we call paresthesias. Usually those symptoms also go wherever that nerve goes. And we'll talk about the distributions that are unique to each of the common nerves as well. Now, it is important to say that the numbness distribution is not always well demarcated. So it might be that two people with a C6 radiculopathy could have numbness patterns that are a little bit different, and that just has to do with the way the nerves conduct after they leave the cervical spine. So cervical radiculopathy is really a fairly common thing to encounter clinically. It's common for patients to have when they have cervical spondylosis. So I want to take a minute or two to drill down on the typical distributions that we see with the common radiculopathies. So the ones I'm going to particularly focus on are going to be C6 and C7, which are the most common levels to encounter on a day-to-day basis. We'll talk a little bit about C5, C8, and then some of the upper cervical ones as well. So these are interestingly dermatome maps. So a dermatome is an area of the skin that is supplied by a specific spinal nerve. So what you can see here is that the cervical spine, which here you can kind of see is the top part of your spine, really mediates most of the symptoms into the arms. So you can kind of see these kind of green areas over here. This is looking at somebody from the back. This is looking at them from the front. So the distribution for the cervical nerves is mostly into the kind of upper neck and down into the arms. That's the classic distribution for it. You can see the thoracic spine kind of does this part of the body. The lumbar spine will do the lower part of the body. It's part of the reason, again, myelopathy can affect everything down below. But radiculopathy, again, just affects the distribution for that specific nerve. And so you can see where they break down here. Now here you can kind of see, if we zoom in a little bit, this is looking at somebody from the front, this is looking at them from the back, and that's so you can see the full distribution, kind of a little bit kind of in 3 dimensions in terms of where the symptoms go. So when people develop symptoms of a C6 radiculopathy, let's talk about that one first. That's usually from the C5-6 disc. A C6 radiculopathy distribution, again, of pain, weakness, numbness, tingling. The pain usually travels down the arm and classically into the forearm, down into the thumb and index finger. Those are the classic kind of distribution for a C6 radiculopathy in terms of pain and even in numbness. In terms of weakness, people will have some difficulty sometimes with bicep weakness, wrist extension, sometimes something called pronator teres returning. Those are not things you need to kind of bother with too much, but people will have specific weakness for the C6 nerve, and those are things that a doctor will typically look at when evaluating for a C6 radiculopathy. But so where does the pain go? Classically down the arm, forearm, down into the thumb and the index finger. A C7 radiculopathy is that's the next one to talk about really. That's usually from the C6-7 level. The typical distribution is down the back of the arm, kind of back of the forearm, down to the back of the hand, kind of classically the middle finger. That's where people will typically describe it. Now there's variability in all of these because everybody's a little bit different, but as a general rule, the middle finger is the most common affected. I've had people would say it's these two, all three, just the middle one, but the point is it's typically down the back of the arm, down classically into the middle finger. That's a C7 distribution for a radiculopathy. Now C5 is probably a third most common, typically into the shoulder. That's the typical distribution for the symptoms that people will get. They can have weakness in the bicep, that's a common, and then weakness in the deltoid. That's a common muscle group for them to have weakness in with the C5 radiculopathy. But the classic pain distribution is really kind of the shoulder, kind of this portion of the arm there. C8's a little bit less common. You'll see it from the C7-T1 level. You'll see a C8 radiculopathy, and it's typically this portion of the arm. There's other things that you have to exclude as well, but that's where C8 classically goes. People will have problems with the hand, kind of finger extension, with the C8 radiculopathy as well. So the ones we really highlighted here in terms of where the symptoms go are C6, C7, which are the most common, a little bit of C5, and a little bit of C8 as well. The upper cervical ones, and you can see that kind of illustrated a little bit here, but there's a lot more variability in this. The upper cervical nerves can cause symptoms into the neck. And upper cervical radiculopathy, which is C2, C3, to some extent C4. C4 is classically kind of here in the trap and kind of whatever people call the neck or the shoulder. C3 is often kind of the neck up here, kind of the back of the head if it's C2. All that distribution, there's a lot of things that can cause those symptoms. So upper cervical radiculopathy almost warrants its own discussion, but those are much less common. If you end up having symptoms like that, there's a bit of a workup that has to be done to verify that that's actually where the symptoms are coming from. But C6, C7, C5, and C8, those are much more common, and that's what I really wanted to show with the help of these two illustrations. So now that we've discussed the symptoms that patients will experience with cervical radiculopathy, we'll talk about the exam findings that might be encountered as well. If you go see a clinician or a spine specialist to get an examination to evaluate for cervical radiculopathy, they typically will look at motor weakness or muscle weakness. Again, the muscles involved will be the same muscles that are innervated or supplied by that nerve. So again, for C6, it's specific muscles, for C7, it's specific muscles, but most times a clinician will do a comprehensive motor exam and kind of see what muscles are involved to kind of correlate that with the symptoms that you might be having. In addition to weakness and asking you about your symptoms, they will also check for numbness, and they'll often involve a sensory exam to kind of see what distribution, to see if everything kind of lines up around cervical radiculopathy as an explanation for the symptoms that people have. Lastly, they'll really check for reflexes. And just like with myelopathy, where you're looking for brisk reflexes, here you're looking for diminished reflexes. So often the reflexes will be either gone or reduced, very different from myelopathy, but that also is a sign. And again, we're not just looking for reduction in reflexes, we're looking for specific reduction. So specific muscle groups. So for C5 is the bicep reflex diminished. For C6 is brachioradialis diminished. We're looking at specific correlation so that we can say, like, yes, this pattern of symptoms that they came in with really does correlate to the MRI and is explained by cervical radiculopathy. One interesting finding that people will have when they have cervical foramen, like narrowing and compression of the nerve with cervical radiculopathy, is something called a Sperling's sign. So you could imagine, for example, if you look up here, if there's pressure on the nerve here, for example, and let's say that nerve is inflamed, or let's say this nerve right here is inflamed, if you were to lean your head towards that and almost pinch on the nerve that's inflamed, it typically would trigger symptoms of radiculopathy, so pain shooting down the arm wherever that nerve goes. So the way that that's done typically is that you kind of have people lean their head, turn their head, or extend their head to kind of squeeze down on that foramen or squeeze down on the nerve to see if it recreates the symptoms into the arms. So the reason that's important is because patients don't come in with a diagnosis of cervical radiculopathy. They might come in with pain with traveling down their arm. You get an MRI scan and it may fit, the distribution might fit, maybe the reflex is motor. The more that fits, the more likely it really is coming from that. And a Sperling's maneuver is a very reliable way. If somebody comes in with arm symptoms, but then you turn your head and lean back and it recreates the arm symptoms, you could say with some degree of confidence that yes, it likely is cervical radiculopathy. After all of that determination is done, we'll still sometimes proceed with EMGs or get injections and other kind of treatments that will help corroborate that as well. But we want to see how much stuff really lines up around it, and the Sperling sign is a very valuable sign for looking at that. Now, cervical radiculopathy is a little bit different in many regards. I guess it's quite different from cervical myelopathy, but the natural history or the course that cervical radiculopathy takes is usually self-limited. What that means is it usually gets better with conservative treatment and time. So we'll try injections, try physical therapy, maybe chiropractic, things like that. We will talk more about that in subsequent chapters about the non-surgical management options for cervical spondylosis, but cervical radiculopathy tends to get better. If it does not get better with conservative treatment, then it tends to do great with surgery. And there's different surgical options for cervical radiculopathy that we'll get into in subsequent chapters when we talk about decision-making around surgery and how you manage each thing. But cervical radiculopathy, as a rule, radiculopathy does tend to get better with time and with conservative treatment. And so we generally encourage people to exercise some patience, try non-surgical stuff before jumping in and doing something surgical for radiculopathy. So now we've really had a chance to discuss the signs, symptoms, distribution of cervical radiculopathy, and we'll change gears next and talk really about the last of the three patterns, neck pain. So now we have discussed two of the three patterns of symptoms that we see with cervical spondylosis. We discussed cervical myelopathy and the signs and symptoms associated with that. We've discussed cervical radiculopathy. Both of those symptom constellations are related to nerves, either the spinal nerves, the spinal cord. The last category of symptoms to talk about is neck pain. Now, neck pain can have various different causes. There's a lot of different things that can cause it, some of which relate to the cervical spine, like you can see here, but many of which have nothing to do with the cervical spine. They can come from muscles, headaches can cause it, other visceral things, chest pain, heart problem, all kinds of things, esophagus, swallowing dysfunction, ENT problems. There's a variety of things that can be associated with neck pain. So traditionally, if a patient comes in with neck pain alone, it's something we do not recommend surgery for, but often we'll get a workup. I mean, we'll get imaging, an MRI, CAT scan, make sure there's not something very concerning that could be contributing to it. But let's talk a little bit about what neck pain is and how it can relate to the cervical spine. So Here's again this image that we showed before, a frozen section, kind of a sagittal slice that's taken through the cervical spine. And you can see the discs at the top look pretty good. Here you can see there's some disc degeneration that's more pronounced. It just doesn't have the sponginess and the whiteness, so to speak. Here, you can see here it's a little drier and a little bit less spongy. This is the front part of the spine. Here you can see the foramen here. There's not much in the way of foraminal stenosis, but you can see the joints. This joint looks beautiful, a little bit irregular here. It gets a little more irregular as you go down. The person has a little bit of bone spurring here, but certainly you can have a fair amount of arthritis in the neck or spondylitic changes in the cervical spine that can cause neck pain. Of course, that is a potential mechanism for it. Sometimes from the joints, and we call that facet-mediated pain. Sometimes from the disc itself or discogenic pain. Remember again that these structures, and here you can see a little bit of it, are kind of wrapped in muscle though, and the muscle and fascia, all of those things can cause it. You can have, everybody's had like a muscular sprain or strain injury at some point, kind of pull your neck, sleep wrong, something like that. Those are muscular injuries that can cause neck pain as well. So there are a lot of paraspinal structures, or structures that are around the spine that can cause neck pain as well. And all of that can present as just run-of-the-mill kind of neck pain. There are other forms of neck pain that can come from the cervical spine. There's radicular neck pain, which we had discussed briefly when we talked about upper cervical radiculopathy. So C2, C3, C4. C4 will often cause pain here. C2 and 3 can cause kind of pain here and kind of pain up higher than that. So sometimes people can have nerve root related neck pain. It's really a diagnosis of exclusion, which means you have to make sure there's nothing else. You have to really verify that it's truly coming from that before recommending anything more aggressive in terms of treatment for it. The lower cervical nerves can sometimes cause neck pain, but it's somewhat unreliable. So I would say in aggregate, when you think about neck pain, it's something that we tell people the treatment options for that are generally non-surgical. Physical therapy, chiropractor, acupuncture, yoga, Pilates, there's a variety of things that you can try. We generally do not recommend surgical intervention for neck pain, and neck pain tends to be self-limited, tends to get better with time as well, and that's part of the reason that we try not to do anything irreversible for it. In this chapter, we've covered the symptoms of cervical spondylosis. We started by having an overview of the different patterns that we encounter with it. We drilled down a little bit to talk about an important one, cervical myelopathy, to discuss not only the distribution of symptoms that people will get, but also the exam findings that we encounter with myelopathy. Then we switched gears to talk about cervical radiculopathy. There we talked about the distribution again and the symptoms that people would encounter. We kind of talked a little bit more in detail about common ones like C6 and C7 radiculopathies, as well as some of the lesser common ones. Then we switched gears to talk about neck pain to the extent that could be attributed to cervical spondylosis. Now, although people's symptoms can be categorized in these different patterns, it's important to recognize that patients will often have features of many of these. They may not have all of them, but when we really drill down and understand the symptoms that people have, that will help really individualize the treatment that we would recommend. So by understanding specifics of their symptoms, then we can decide not only what types of treatment to employ, but the timing of that treatment. So all of that is dictated by a very clear understanding of the symptoms that people have. In the next section, we're going to really change gears to the important topic of management of cervical spondylosis. We'll start by talking about non-surgical management, including things like physical therapy, injections, and other modalities. But then in subsequent chapters, we're really going to get into the surgical decision-making, so figuring out what treatment to employ for what patient. And then we'll really kind of drill in a lot into the specifics of different surgical procedures to talk about the techniques themselves, the risks, benefits, so people can really have a better understanding of what that specific technique is. Thank you for watching. I hope you've found this to be a valuable video, and I look forward to seeing you in a coming chapter.